Okay, let's dive in. Imagine for a moment a tiny gland, literally the size of a pea nestled deep within your brain. It might be small, but this little powerhouse is the master conductor of your entire endocrine system, orchestrating everything from your growth and metabolism to your stress response and even reproduction. Now picture what happens when a mass, a growth, forms in this unbelievably crucial control center. Today, we're taking a truly comprehensive, in-depth journey into pituitary masses and adenomas. Our mission is to equip you with an understanding so thorough, so nuanced, you'll master this complex topic like an elite professional in the field.
It's a fascinating challenge because these small formations can indeed create an astonishingly diverse range of clinical pictures, from the most subtle, almost imperceptible changes to truly life-altering syndromes. This deep dive is built from an authoritative medical text, and we're going to distill all the critical and surprising insights, turning complex biology into a compelling and deeply informative conversation.
Let's start by pinpointing this remarkable little gland. Where exactly is the pituitary and what are its core functions?
The pituitary gland is strategically situated in a unique, bony, saddle-shaped depression at the base of your brain, called the sella turcica. Think of it as a perfectly protected central hub, tucked away right beneath your brain, yet above the nasal passages. It's really the nerve center for hormonal regulation.
And it's not just one uniform unit, is it? It's got two incredibly distinct parts, each with its own incredible story.
Precisely. It comprises two main lobes, the anterior and the posterior. The anterior lobe is quite remarkable in its origins. It actually arises embryologically from something called Rathke's pouch, which is a bit of tissue that came from the roof of your developing mouth-oral ectoderm.
Wow, from the mouth, that's unexpected.
It is, and this lobe is the true workhorse for secreting what we call trophic hormones. Think of trophic as feeding or stimulating. These are the command signals that tell other major endocrine glands in your body to get to work. We're talking about adrenocorticotrophin, or ACTH, which signals your adrenal glands, growth hormone, GH, follicle-stimulating hormone, FSH, and luteinizing hormone, LH, which regulate your reproductive system, prolactin, PRL, important for milk production, and thyrotrophin, or TSH, which controls your thyroid.
Okay, the whole suite of critical hormones.
Exactly. And the critical part is how precisely these are controlled. Specific signals, releasing or inhibiting hormones, come from the hypothalamus, a part of your brain just above the pituitary. These signals travel down a specialized superhighway of blood vessels, the pituitary stalk portal system, to act on specific cell surface receptors in the anterior pituitary.
So the hypothalamus is constantly sending these precise chemical instructions to the anterior lobe. What about the posterior lobe? Does it operate on the same system?
Not at all, which is one of the most intriguing differences. The posterior lobe isn't a gland in the traditional sense. It's primarily a neural extension, almost like a direct wire from the hypothalamus itself.
A direct wire.
Pretty much. It doesn't produce hormones in the same way, but rather it synthesizes and then secretes two key hormones: oxytocin, known for its role in bonding and childbirth, and arginine vasopressin, AVP. You might know AVP as antidiuretic hormone, or ADH, crucial for water balance. Crucially, its secretion is directly controlled by nerve signals, independent of the hypothalamic hormonal control seen in the anterior lobe. It's a neural release, not a hormonal cascade.
It's truly fascinating how two parts of the same small structure have such different wiring. Now, when we talk about pituitary masses, what are we predominantly dealing with, and should we be immediately alarmed?
Well, the overwhelmingly reassuring takeaway here is that intrapituitary or parasellar masses, meaning masses within or right around the pituitary gland, are mostly benign pituitary adenomas. These are non-cancerous growths.
Okay, that's a huge relief for most cases, but you did say mostly.
Yeah.
What are the rare exceptions, the ones that aren't adenomas?
Right. While adenomas dominate, there are rare instances of non-adenomatous sellar masses. This can be various things: inflammatory processes like hypophysitis, infiltrations like sarcoidosis, or even metastatic deposits from cancers elsewhere in the body, although that's quite rare for this specific location. They can also arise from adjacent structures that just happen to be in the vicinity, including aneurysms, which are like ballooning blood vessels, meningiomas, which are tumors of the brain's protective membranes, or chordomas, which are very rare bone tumors. So while an adenoma is the most common, a thorough diagnostic approach is always paramount to rule out these other, sometimes more serious possibilities.
That makes perfect sense, starting broad and then meticulously narrowing down. Now let's zoom in specifically on pituitary adenomas. How do medical professionals categorize these growths, and what do these classifications tell us about their characteristics and potential impact?
We use a multifaceted approach to classify pituitary adenomas, and each layer helps us understand the tumor's behavior and guide treatment. There are two primary systems. One based on what we see on imaging and during surgery, and another based on what the cells look like under a microscope pathology.
Let's start with the imaging and surgical classifications, like the Hardy and NOSP scales. What do those reveal?
These systems primarily categorize tumors by their localization, their size, and importantly, their invasiveness, meaning how much they've pushed into or beyond the boundaries of the cella. We call them microadenomas if they're confined within the cella and are smaller than 10 millimeters in diameter. That's less than half an inch.
Tiny.
Very. Then we have macroadenomas, which are 10 millimeters or larger, and because of their size, these are the ones that more frequently start impinging on surrounding structures. And in truly rare but sometimes dramatic cases, we encounter giant adenomas, which are exceptionally large, measuring 40 millimeters or more, like some of the massive prolactinomas we'll discuss. The size and invasiveness are critical for surgical planning.
Okay, so imaging tells us about size and spread. What about the pathologic classification? That sounds like it takes us down to the very cellular level.
It does, and it's critical for truly understanding these tumors. Pathologic classification identifies the specific cell type origin of the adenoma using what we call transcription factors, proteins that turn genes on or off, and hormone immunochemistry, which detects hormones within the cells.
Oh, okay.
For instance, the PIT1 lineage includes somatotrophs, which produce growth hormone, lactotrophs, which produce prolactin, and thyrotrophs, which produce TSH. Sometimes these can even be plurihormonal, meaning they secrete more than one hormone, adding to their complexity.
Right.
Then there's a TPIT lineage, which accounts for corticotrophs, the cells that produce the ACTH precursor, POMC. These can be densely or sparsely granulated, referring to how packed they are with hormone storage vesicles, or even a specific type called Crooks cell adenoma, which has distinct microscopic features. The SF1 lineage comprises gonadotrophs, which secrete FSH, LH, and alpha subunit, primarily linked to reproductive function.
And what about those that don't seem to make hormones?
Exactly. Finally, we have null cell adenomas. These are particularly intriguing because, despite being tumors, they don't produce any differentiated hormone product that we can detect clinically. They account for about 1 to 2% of surgical series and are often more aggressive in their growth patterns, highlighting that not all non-secreting tumors behave the same way.
That's an incredible level of detail and classification. So, armed with this knowledge, how do these adenomas actually make their presence known in a person's life? What are the typical clinical features you'd observe?
They generally present in two main ways. First, through compressive symptoms, which are direct physical effects due to the tumor's presence and growth, and second, through hormonal manifestations, which are due to either too much or too little hormone production.
Let's start with those compressive symptoms. Headaches are a very common complaint, even with small tumors, right?
Absolutely. Headaches are exceptionally common, even with microadenomas. This often surprises people, but it happens because the tumor, even if small, can stretch the dural plate, the tough membrane that encases the brain and pituitary within the confined space of the cella.
Makes sense.
The good news is that these headaches often resolve remarkably well with successful medical or surgical management once the pressure is relieved.
And visual disturbances. That's a classic symptom, especially if the tumor grows upwards towards the optic nerves.
Indeed. It's fascinating how much this has changed. Historically, virtually all pituitary mass is presented with visual loss. Now, thanks to advanced imaging and incidental discoveries, less than 10% of patients present primarily with visual symptoms.
That's a big shift.
Huge. But when they do occur, the visual loss is often asymmetric and can develop insidiously, meaning slowly and subtly. The most common pattern is bitemporal visual loss, a unique kind of peripheral vision loss, where you lose vision on the outer sides of both eyes. This occurs because the adenoma impinges directly on the inferior crossing chiasmal fibers of the optic chiasm, which is where the optic nerves from both eyes meet and cross.
Right, the crossing point.
Exactly. This can progress to more severe issues like acuity loss, optic atrophy, where the optic nerve itself is damaged, papilloma swelling of the optic disc, or even lead to cranial nerve palsies affecting eye movement, nystagmus, and in very rare cases, even visual hallucinations. It's a stark reminder of the delicate anatomy there.
That's quite a spectrum of visual effects, and it sounds like the direction of tumor growth is critical. What if the tumor grows in other directions beyond just pressing on the optic chiasm? Can it invade other parts of the brain or skull?
Yes, aggressive adenomas can indeed show significant invasion, and this determines a lot about their clinical impact. Downward extension can erode the bony sellar floor and invade the sphenoid sinus, a hollow space behind your nose. Sometimes they can even invade the roof of the palate, leading to uncomfortable nasopharyngeal obstruction or, critically, cerebrospinal fluid leakage, which can be a serious complication.
CSF leak, yeah, that's
Well,
serious.
very. Less frequently, they might invade parts of the temporal or frontal lobes of the brain, which can cause very specific neurological symptoms like uncinate seizures, changes in personality, or anosmia, the complete loss of your sense of smell. Another common area of invasion is the cavernous sinus, a major venous channel right next to the pituitary. Invasion here can directly affect cranial nerves 3, 4, and 6, which are responsible for controlling eye movement, leading to double vision or problems moving the eyes.
So the physical location and direction of growth are incredibly important, guiding both diagnosis and treatment. And then there are the hormonal manifestations you mentioned. How do those present?
Sure. Right. These fall into two crucial categories. First, hyposecretion, where the adenoma cells are actively producing and releasing too much of a specific hormone. This leads to distinct, sometimes dramatic, clinical syndromes like those seen in prolactinomas, acromegaly, Cushing disease, or TSH-secreting adenomas. The tumor essentially acts as an uncontrolled hormone factory.
Like a rogue factory.
Exactly. The second category is hypopituitarism, which is hormone deficiency. This occurs when the growing mass compresses the healthy, normal pituitary tissue, or if it disrupts that critical pituitary stalk portal system, attenuating the hypothalamic hormone signals. This can lead to a deficiency in any of the anterior pituitary hormones like growth hormone, gonadotrophins, TSH, or ACTH. The encouraging news, though, is that sometimes after successful surgical decompression, some of these compromised anterior pituitary functions can recover.
That's good news. And what about those cases where a mass is found, but the person isn't experiencing any of these clear symptoms, either from compression or hormone imbalance?
Those are what we call incidentalomas. These are pituitary masses discovered purely by chance during imaging, like an MRI or CT scan, performed for an entirely unrelated condition. There are no clear clinical symptoms directly related to the pituitary at the time of discovery.
Just found by accident?
Pretty much. And with the widespread use of advanced imaging technologies for various medical conditions, the detection of these incidentalomas is increasing significantly, making up a growing proportion of new pituitary diagnoses. They represent a unique challenge. How do we manage something that's there but not causing obvious trouble?
This is where it gets really interesting because we're moving from the general impact of these masses to the specific functional types of adenomas, each with its own unique biochemical and clinical fingerprint and very specific management challenges. Let's start with the most common functional adenoma, prolactin-secreting adenomas, or prolactinomas.
Prolactinomas are indeed the most frequent functional adenoma, making up more than 75% of all pituitary adenomas diagnosed in women. However, there's a striking sex difference in how they present. Men often come to diagnosis with significantly larger, more invasive tumors, largely due to a delayed recognition of their less obvious initial symptoms.
Why the delay in men?
The symptoms are often less specific. Initially, maybe decreased libido, some fatigue, erectile dysfunction, things that can be attributed to many other causes. So it often gets missed until the tumor is quite large. This is reflected in their mean serum prolactin levels, which are often dramatically higher in men. For example, one study reported a mean of 2,789 nanograms per milliliter in men versus 292 ng/ml in women.
Wow, a huge difference. So what are the specific clinical features that point to a prolactinoma?
The symptoms primarily arise from hyperprolactinemia, which is an excess of prolactin. In women, this typically leads to galactorrhea, inappropriate milk production infertility, and menstrual irregularities, most commonly amenorrhea, the absence of periods. In men, it primarily causes sexual dysfunction, erectile dysfunction, decreased libido, and oligoisospermia, which is low sperm count. Both sexes, especially with larger tumors, can also experience the mass effects we discussed: headaches and visual field defects.
What's the underlying pathology of these tumors? Are they usually aggressive?
Over 99% of prolactinomas are benign, meaning they are non-cancerous and do not metastasize. They can be sharply demarcated, meaning clearly defined, or they can invade local parasellar structures. Histologically, there are three main subtypes: the common sparsely granulated, the rare densely granulated, and the acidophil stem cell type. A specific, sometimes more problematic entity, giant prolactinomas, accounts for less than 5% of cases. These are typically larger than 40 millimeters in diameter, have incredibly high prolactin levels, often over 1,000 ng/ml, and exhibit a striking 9.1 male preponderance, reinforcing why men often present with more advanced disease.
And how does this excess prolactin production actually happen? What's the molecular switch that gets flipped?
Physiologically, the hypothalamus tonically inhibits prolactin release. It's constantly sending dopamine down the pituitary stalk to keep prolactin levels in check.
Right, dopamine is the brake.
Exactly. In prolactinomas, the tumor cells are autonomously resistant to this normal dopamine inhibition. They just ignore the stop signal. It's also crucial to remember that any mass lesion, even a non-prolactinoma tumor or a cyst, that blocks or impedes the delivery of hypothalamic dopamine to the pituitary stalk can lead to enhanced prolactin release by otherwise normal pituitary lactotroph cells. This is called the stalk blockade effect, and it's a critical differential diagnosis for elevated prolactin.
That's a really important distinction for diagnosis. So how do you definitively diagnose a prolactinoma, separating it from these other causes of elevated prolactin?
The diagnosis requires two key elements working together. First, sustained hyperprolactinemia, with a serum PRL level over 200 ng/ml being strongly indicative of a prolactinoma. Levels below that, especially below 100, are more likely stalk effect.
Okay, the level matters.
Very much. Second, MRI evidence of a pituitary mass. It is absolutely vital to thoroughly exclude other secondary causes of hyperprolactinemia, such as pregnancy, the use of certain neuroleptic medications, which can block dopamine, severe hypothyroidism, acromegaly, or even kidney failure.
Once diagnosed, what are the management strategies for prolactinomas?
The management typically involves medical therapy, surgery, or, in some cases, radiation therapy.
And medical therapy is usually the first-line approach, correct?
Yes. Medical therapy with dopamine agonists, DAs, is the cornerstone and first-line treatment for almost all prolactinomas. Cabergoline, taken once or twice weekly, is significantly superior to bromocriptine, which typically requires daily or more frequent dosing. Cabergoline boasts higher efficacy, normalizing PRL in 83% of women compared to 52% with bromocriptine. It's much better tolerated, and it's more effective at shrinking tumors.
How do they shrink the tumor?
DAs work by reducing tumor volume, literally shrinking the size of the tumor cells, and directly inhibiting prolactin synthesis and release. However, it's important to note that about 15% of patients show resistance to DAs, which might require higher doses or could signal that the mass isn't a typical prolactinoma at all.
So DAs are remarkably effective. When is surgical therapy considered as an option?
Surgery is a viable alternative, especially for microprolactinomas, where prolactin normalization rates can be as high as 90% following surgery by an experienced surgeon. For macroadenomas, the results are less favorable, with initial normalization rates between 50–75% for selected cases and recurrence rates ranging from 19–45%.
When would you definitely opt for surgery?
Surgery is specifically indicated for situations like significant visual loss that needs rapid decompression, dopamine agonist-induced CSF rhinorrhea, a rare but serious side effect where spinal fluid leaks through the nose, if the tumor has hemorrhagic components endangering visual pathways, or for pre-pregnancy risk mitigation, especially with macroadenomas where significant expansion during pregnancy is a concern. Surgical success is highly linked to the surgeon's experience, smaller tumor size, lower preoperative prolactin levels, and the absence of cavernous sinus invasion.
And radiation therapy, when does that come into play?
Radiation therapy is generally reserved for malignant prolactinomas, which are exceedingly rare, or for cases that are resistant to medical therapy and have failed surgical attempts. It's also used when surgery isn't possible. It takes a surprisingly long time to achieve maximal efficacy. For example, prolactin normalization was seen in only 50% of patients at a mean of 7.3 years post-treatment with older techniques.
That's a long time.
It is. Stereotactic radiosurgery using techniques like gamma knife or proton beam is preferred now as it precisely targets the adenoma, proving effective for growth control, often faster than conventional radiation.
What about managing prolactinomas specifically during pregnancy? That sounds like a very delicate situation.
It absolutely is. Cabergoline is typically discontinued upon pregnancy confirmation. The risk of tumor re-expansion for microadenomas during pregnancy is fortunately very low, less than 5%. However, for macroadenomas, the risk is considerably higher, around 50%, due to the physiological increase in pituitary size during pregnancy.
So what do you do?
Careful monitoring is key, often including visual field testing each trimester. In some cases, for very large macroadenomas, prophylactic surgical resection might even be considered before pregnancy to mitigate the risk of symptomatic enlargement during gestation.
Moving on to another significant but less common functional adenoma. Acromegaly, which is caused by GH-secreting adenomas. How common is this condition?
The prevalence of acromegaly is estimated to be between 28 to 137 cases per million people, which makes it quite rare. However, the annual incidence, meaning new diagnoses each year, is increasing, now around 10 cases per million. This suggests we're getting better at detecting it.
What's the fundamental cause of acromegaly at the cellular and genetic level?
Acromegaly is primarily caused by pituitary adenomas that autonomously secrete growth hormone, accounting for about 98% of cases. Rarely, it can be due to extrapituitary disorders secreting GH or GHRH. The core pathogenesis involves chronically elevated levels of both growth hormone, GH, and insulin-like growth factor 1, IGF-1. It's this sustained elevation that drives the characteristic features.
Are there specific gene mutations involved?
Yes. Key driver mutations include GNAS mutations found in up to 40% of GH-secreting adenomas. These mutations constitutively activate the GSOP protein, which acts like a stuck accelerator pedal, leading to permanently increased cyclic AMP-CAMP within the cell and uncontrolled GH hypersecretion. These adenomas often tend to be smaller and more responsive to somatostatin receptor ligands. These same mutations are also found in McCune-Albright syndrome, a rare genetic disorder. Also, germline AIK mutations are found in familial somatotropinomas, often leading to large, aggressive tumors diagnosed at a younger age.
The clinical features of acromegaly are quite striking, but often insidious in onset. What should someone, or even a healthcare professional, look for?
The onset is indeed insidious, often leading to a significant diagnostic delay of 5 to 6 years, which is why early detection is so crucial. The characteristic features include acral enlargement, meaning enlargement of the extremities and facial features. Think spade-like hands and feet, a large nose, thick lips, frontal skull bossing or prominent forehead, and an increase in shoe, ring, or hat size.
Things people might notice over years.
Exactly. Other common signs are hyperhidrosis, which is excessive sweating, oily skin, skin tags, macroglossia, an enlarged tongue, prognathism, a prominent jaw interdental separation, and a deepening of the voice. Patients frequently develop debilitating arthropathy, affecting up to 70% of cases, and carpal tunnel syndrome in up to 50%.
And systemically?
Systemically, sleep apnea, hypertension in about 50% of patients, left ventricular hypertrophy enlargement of the heart's main pumping chamber cardiomyopathy, and diabetes mellitus in about 20% are common. It also significantly impacts quality of life, often leading to depression and anxiety. The profound impact on multiple body systems means diagnosis often comes too late.
It sounds like it can affect nearly every system in the body. And tragically, it increases mortality.
Yes, there is an increased overall mortality with a standardized mortality rate of 1.72, meaning they are 72% more likely to die than someone without the condition. This is primarily from cardiovascular disease, though recent trends show a concerning shift towards cancer as a cause of death. Predictors of increased mortality include persistently high GH levels, above 2.5 micrograms per liter elevated IGF-1, coexisting hypertension and cardiac disease, older age, a history of pituitary irradiation, and that significant diagnostic delay.
Given that insidious onset, how is acromegaly definitively diagnosed?
Screening is typically done with an elevated insulin-like growth factor 1, IGF-1 level, which reflects chronic GH secretion and is more stable than GH itself. The definitive diagnosis is then made by demonstrating a GH nadir, the lowest point of growth hormone, of less than 1.4 EGL using an ultrasensitive assay, or less than 1.2 EGL with a standard assay after a 75-gram oral glucose load. Normally, glucose should suppress GH, so if it doesn't, that's a key sign.
Glucose suppression test.
Right. This must be coupled with a persistently elevated IGF-1 level adjusted for age and sex. An MRI is then performed to confirm the presence of a pituitary lesion.
Once diagnosed, what are the treatment goals and available options for acromegaly?
The comprehensive goals are to aggressively suppress GH and IGF-1 levels to normal, control tumor growth, relieve any compressive effects, preserve overall pituitary function, and critically, to normalize mortality. The main therapeutic modes are surgical, radiotherapeutic, and medical.
So surgical management is often the first step.
Yes, transsphenoidal surgical management entering through the nose is generally the preferred primary treatment for well-circumscribed adenomas. It leads to rapid and often dramatic improvement in metabolic dysfunction and soft tissue swelling. Remission rates are quite good, around 73% for microadenomas and 61% for macroadenomas. Surgical success is strongly predicted by factors like the surgeon's experience, a smaller adenoma size, a lower NOSP score indicating less invasiveness, and lower preoperative GH and IGF-1 levels.
What are the risks?
Like any surgery, there are potential side effects, including hypopituitarism in about 15% of patients, AVP deficiency, meaning diabetes insipidus CSF leaks, and hemorrhage. Recurrence, even after successful surgery, is seen in about 7% over 10 years.
And what if surgery isn't enough or isn't a safe option for the patient?
Then radiation therapy is considered, either as a primary treatment or as an adjuvant after surgery. Stereotactic radiosurgery, such as gamma knife or proton beam, is highly effective in precisely targeting the adenoma, controlling its growth, and causing shrinkage over time. IGF-1 normalization is achieved in about 59% of patients, typically around 38 months after treatment. However, side effects include a significant risk of new-onset hypopituitarism, up to 50% in 10 years, and the rare visual or cranial nerve issues or cognitive dysfunction.
Finally, let's unpack the medical management options for acromegaly, which seems quite varied.
It is. For medical therapy, dopamine agonists like cabergoline have a modest effect, normalizing IGF-1 in up to a third of patients with mild elevations, and are often used as an adjuvant, particularly if prolactin is also elevated. The true mainstay, however, are the somatostatin receptor ligands, or SRLs, such as octreotide, lanreotide, and pasireotide. These drugs bind to specific receptors, SST2 and SSD5, on the tumor cells.
How do they work?
They powerfully suppress GH secretion and can shrink tumor volume by about 59% in responders. Beyond hormone control, they dramatically improve symptoms like headache, soft tissue swelling, sleep apnea, and even cardiovascular function. IGF-1 normalization rates with SRLs range from 55–65%. An oral octreotide formulation is also now available.
Any downsides?
Side effects can include GI issues, gallstones, and hyperglycemia, which is more common with pasireotide. Tumor responsiveness often correlates with how much SST2 expression is present on the tumor cells and whether the GH cells are densely granulated. Then there's the GH receptor antagonist, pegvisomant. This one is different. It doesn't affect the tumor itself, but blocks GH action at the tissue level, leading to IGF-1 normalization in over 65% of patients. It requires careful liver enzyme monitoring.
And if one drug isn't enough?
For the most resistant cases, combination therapy with SRLs and pegvisomant is often very effective. It really requires a tailored approach.
That's a powerful arsenal of treatments, really tailored to the individual. Let's move to another rare but incredibly impactful functional adenoma, ACTH-secreting adenomas, which cause Cushing disease.
Cushing disease is indeed quite rare, with an annual incidence of about 1.6 cases per million, but it's critically important because it's the most frequent cause of endogenous Cushing syndrome, meaning Cushing syndrome caused by something inside the body rather than outside sources like medication.
And the clinical features are those of hypercortisolism, which can be quite dramatic and debilitating, right?
Yes, the symptoms arise from chronic excess cortisol and are indeed striking. Central obesity with slender limbs, facial plethora, a flushed, rounded face, often called a moon face, hypertension, diabetes mellitus, increased susceptibility to infections, easy bruising, skin thinning, purple stretch marks, and dyslipidemia. What makes diagnosis so challenging is that these adenomas are typically very, very small, often less than 2 millimeters in diameter, making them difficult to spot on imaging.
So how is the diagnosis confirmed, especially with such tiny tumors? It requires a very high clinical suspicion. Laboratory tests are the gold standard for initial diagnosis. We look for elevated 24-hour urinary-free cortisol, elevated late-night salivary cortisol, and crucially, a failure to suppress cortisol after a low-dose dexamethasone test, which normally should suppress cortisol.
Okay, multiple tests needed.
Yes, often several rounds. Persistently non-suppressed serum ACTH levels point to a pituitary source, as opposed to an adrenal source where ACTH would be low. Even with all these clues, MRI can be difficult, as only about 50% are detected with a standard 1.5T MRI.
So what do you do if the MRI is negative?
For precise localization, particularly when imaging is inconclusive, inferior petrosal sinus sampling is often necessary. This invasive procedure involves taking blood samples directly from the veins draining the pituitary to compare ACTH levels there versus peripheral blood. A significant gradient confirms the tumor's location in the pituitary.
And for management once it's confirmed. Transsphenoidal surgery is the preferred primary treatment. It's an intricate dance given the tiny size of these tumors, and localization during surgery is challenging, sometimes requiring exploration of the whole gland. Remission rates are quite good, around 80% for microadenomas and maybe 60% for macroadenomas, but success is highly dependent on the surgeon's specialized expertise.
What if surgery doesn't work or isn't an option?
Medical therapy options include pasireotide, which normalizes cortisol in 20–40% of patients but carries a notable risk of hyperglycemia. Cabergoline has shown variable results. Other steroidogenesis inhibitors like ketoconazole, metropone, or etomidate reduce cortisol production. The glucocorticoid receptor inhibitor mifepristone, which blocks cortisol action, is also used, especially for managing hyperglycemia. Radiotherapy is generally reserved for persistent or recurrent disease or for aggressive adenomas that can't be fully removed. Conventional radiation can take years for efficacy, while stereotactic radiosurgery, SRS, shows faster control, with about 80% control at 5 years. Both, however, carry a significant risk of inducing hypopituitarism over time.
Lastly, we come to the rarest functional adenoma, thyrotrophin-secreting adenomas, or TSH-secreting adenomas.
These are indeed the rarest functional adenoma, accounting for only 0.53% of all functional cases, but their detection is increasing due to the widespread use of more sensitive TSH assays and advanced MRI.
What are their key clinical hallmarks?
Patients typically present with symptoms of hyperthyroidism, just like an overactive thyroid gland, including goiter and enlarged thyroid palpitations, weight loss, tremor, heat intolerance, and nervousness. Headaches or visual disturbances are also common because these adenomas are often large macrodenomas at diagnosis.
How is this condition distinguished from other, much more common causes of hyperthyroidism? This seems like a critical diagnostic challenge.
It is absolutely crucial for proper management. The diagnosis is confirmed by finding elevated T3 and T4 levels, your main thyroid hormones, with an inappropriately normal or even elevated TSH level.
That's the key. The TSH isn't suppressed.
Exactly. Normally, if T3, T4 are high, TSH should be suppressed to near zero by negative feedback. So this inappropriate TSH response is the key. An elevated glycoprotein hormone alpha subunit is also a common finding. MRI typically shows a macrodenoma.
What's the main thing to rule out?
The critical differential diagnosis is distinguishing it from primary hypothyroidism with secondary pituitary hyperplasia. In that condition, the thyroid gland itself is underactive, so TSH is high but T4 is low, and the pituitary gland can enlarge in response. The good news is that this pituitary enlargement actually resolves with thyroid hormone replacement, so the inverse relationship of TSH and T4 levels is the critical differentiator.
And what's the management approach for TSH-secreting adenomas?
Medical therapy with somatostatin receptor ligands, SRLs, such as octreotide and lanreotide, is often the mainstay, especially preoperatively or if surgery isn't curative. They normalize TSH and thyroid hormone levels, effectively reduce adenoma volume, and can rapidly improve vision. Dopamine agonists have shown variable results.
What about standard hyperthyroid treatments?
It is absolutely vital to understand that antithyroid drugs or radioactive iodine are generally not recommended as primary treatments for TSH-secreting adenomas, because while they control the hyperthyroidism, they remove the negative feedback from thyroid hormones, which can paradoxically exacerbate tumor growth.
Oh, okay, that's critical.
Very. Surgical resection is the definitive primary treatment, especially for mass effect and to achieve rapid cure. And radiotherapy is considered for residual tissue after surgery or if surgery is contraindicated, with stereotactic radiosurgery, SRS, being preferred for its precision.
So many intricate details to understand these functional types. Now let's pivot to non-functioning pituitary adenomas, or NFAs, and then broaden out to other non-adenomatous growths in the pituitary and parasellar regions. What defines an NFA if it's not producing excess hormones?
Non-functioning pituitary adenomas are a significant group, accounting for between 30% to 55% of all pituitary adenomas. Their defining characteristic is that they are associated with a pituitary mass, but crucially, they lack any clinical or biochemical evidence of hormone hypersecretion. They don't cause the overt syndromes like galactorrhea, acromegaly, or Cushing disease that we've just discussed.
So without hormone excess symptoms, how are these typically discovered?
Traditionally, they were detected later in their course due to compressive neurologic signs associated with larger macrodenomas, things like severe headaches or vision loss. However, their presentation has shifted dramatically. With the widespread use of imaging for unrelated conditions, someone might get an MRI for persistent headaches. For example, incidental detection has doubled in the last 20 years, now approaching 50% of all NFAs at presentation.
So we're finding them smaller now.
Exactly. This means we're finding more microdenomas that are non-functioning, often equal in number to macrodenomas. Interestingly, men tend to be older at presentation and typically have larger adenomas compared to women.
Even though they don't hypersecrete, do they affect hormone levels in other ways, like causing deficiencies?
Yes, they frequently cause hypopituitarism or hormone deficiencies by simply taking up space and compressing the healthy pituitary tissue. Most NFAs show some degree of pituitary failure over time. Growth hormone deficiency can be present in up to 85% of patients, and hypogonadism in up to 75%. ACTH and TSH deficiencies are less common.
What about prolactin?
Interestingly, prolactin levels may be mildly elevated, usually up to 100 ng/ml, due to the mass effect causing that stalk blockade we talked about earlier, which interrupts the normal dopamine delivery to the pituitary. This is a common and important clue, often called pseudoprolactinoma.
What's their natural history like if left untreated? Do they usually grow?
That's a critical question for management. Under conservative management, meaning careful clinical follow-up, and serial imaging, macrodenomas tend to increase in size more frequently than microdenomas, about 50–60% versus maybe 12.5% respectively over several years. However, a significant proportion of both can remain stable or even surprisingly decrease in size over years or decades, which is why a wait-and-watch approach is often considered for smaller ones without symptoms.
How do NFAs typically present clinically then, if not with hormone excess?
Their clinical presentation is primarily due to their sheer size, either through direct compression of nearby structures or, as we mentioned, by incidental detection. Patients commonly experience visual deficits due to optic chiasmal compression and headaches. While rare, acute apoplexy, sudden bleed into the tumor, and cranial nerve palsies can occur. About 50% of NFAs will show some infiltration into the cavernous sinus at diagnosis. MRI is crucial for differentiating NFAs from other cellular masses like craniopharyngiomas or meningiomas.
And what's the management approach for NFAs, especially since medical therapy isn't typically effective for size reduction?
You're right, medical therapy for NFAs is generally not effective in reducing adenoma size or improving vision. While some may express dopamine receptors, cabergoline has shown very variable results in stabilizing growth or shrinking remnants. Thus, transsphenoidal surgical resection is the primary treatment for symptomatic NFAs, especially for vision loss or significant mass effect. It rapidly improves visual field defects and headaches in up to 80% of patients and can relieve compressive hormonal deficits. However, achieving gross total removal, completely removing the tumor, is often difficult, especially with larger or invasive tumors.
So, surgery is the main intervention. What about radiotherapy?
Radiotherapy is considered for adenoma mass not completely resolved after surgery or for recurrence. Stereotactic radiosurgery is preferred because of its precision. The role of prophylactic postoperative radiotherapy, meaning radiating a tumor bed even after apparent successful surgery, is debated among neurosurgeons and endocrinologists due to the significant risk of inducing hyperpituitarism down the line. Many opt for expectant follow-up with serial MRIs instead, reserving radiation for proven growth.
And for those incidentalomas or smaller NFAs, you mentioned expectant observation.
Yes. For non-functioning microdenomas or small incidental macrodenomas that aren't causing symptoms or compressing vital structures, expectant observation with serial MRI is often an appropriate strategy. For microdenomas, we might suggest an MRI at 1, 3, and 5 years, then less frequently if stable. Macrodenomas need closer watching initially, maybe 6 months, then annually for a few years. Periodic comprehensive endocrine evaluation is also important, as hypopituitarism can be subtle and develop gradually.
Are there any particular silent subtypes of NFAs that are important to be aware of, even though they don't cause obvious hormone excess?
Yes, pathologically we identify what are called silent corticotroph adenomas. These are fascinating because they immunostain positively for ACTH and POMC, meaning the cells can produce the hormone, but the patient does not present with clinical hypercortisolism. They're typically more aggressive than other non-secreting adenomas, often presenting as hemorrhagic macrodenomas, and interestingly, they have a 2.1 male preponderance. They carry a high recurrence risk after surgery.
More aggressive even though they're silent.
Exactly. Then there are silent subtype 3 adenomas, which express GH/PRL and/or TSH at a cellular level but are clinically non-secreting, and they often show aggressive features and nuclear atypia under the microscope. And finally, silent GH-expressing adenomas, prevalent in about 2% of all pituitary adenomas, should be closely monitored for recurrence or potential progression to clinical acromegaly over time. This highlights that non-functioning doesn't mean biologically inactive.
Now, let's cast a wider net. What about other non-adenomatous sellar and parasellar masses, the ones that aren't typical pituitary adenomas at all, but can look very similar on imaging?
This is a truly diverse group, and differentiating them is critical because their management is often very different. For example, if we see stalk thickening on an MRI, that's a red flag that may indicate hypophysitis inflammation of the pituitary, a metastatic deposit in adults, Or in children, it could point to congenital malformations, germ cell tumors, or Langerhans histiocytosis.
What kinds of cysts can form in this critical area?
We have several types. Rathke's cysts are embryological remnants from that Rathke's pouch we discussed earlier. They are usually asymptomatic, but can enlarge, and if they do, cause panhypopituitarism or AVP deficiency. Most are simply followed expectantly and less symptomatic. Then there are arachnoid, epidermoid, and dermoid cysts. Dermoid cysts can be quite distinctive, sometimes containing calcifications or even hair follicles. These can cause hydrocephalus, visual disturbances, or hormone deficiencies if they grow. Acquired pituitary cysts can also arise secondary to an intrapituitary hemorrhage, a bleed within the gland.
Any other less common but still important types of masses in this region?
Absolutely. A mucalo is an expanding accumulation of fluid within the sphenoid sinus, which can cause headaches, unilateral visual disturbances, and exophthalmos, where the eye bulges out. Blastomas and germ cell tumors are rare, destructive lesions seen mainly in children. Blastomas can sometimes be associated with Cushing disease. Chordomas are slow-growing, locally invasive tumors arising from notochord remnants, often distinguished by osteolytic bony erosion and calcification on MRI, and can cause headaches, visual disturbances, and hormone deficiency. They often require aggressive treatment.
Craniopharyngiomas are another well-known type, aren't they? Especially impactful in children.
Indeed. Craniopharyngiomas account for about 3% of all intracranial tumors and up to 10% of childhood brain tumors, showing a bimodal age distribution, meaning peaks in occurrence in two age groups, 5-14 years and 50-74 years. They originate from embryonic squamous remnants of Rathke's pouch and are often large, cystic, cholesterol-rich, and distinctively can contain calcifications or even tooth-like structures on imaging.
Tooth-like structures.
Yes, it's quite characteristic. Clinically, they often cause symptoms of increased intracranial pressure headache, vomiting, visual disturbances, pituitary deficiency, hyperprolactinemia, but crucially, AVP deficiency is often one of the earliest and most common features. Diabetes insipidus is very common. Management involves radical surgery and adjuvant radiotherapy, with a critical focus on hypothalamus-sparing surgery to mitigate the risk of severe postoperative obesity, a devastating complication. High recurrence rates are common, but targeted therapies for specific mutations like CTNNB1 or BRAF-V600E are showing promising results.
What about meningiomas? How do they differ from pituitary adenomas on imaging and presentation?
Meningiomas arise from arachnoid or meningioendothelial cells, part of the brain's covering. They are usually well circumscribed, meaning clearly defined, and present with headache, progressive visual disturbances, and optic atrophy. They can also, interestingly, cause secondary hyperprolactinemia in up to half of patients simply by compressing the stalk. On CT scans, dural calcification, where the dura hardens, or a dural tail sign on MRI may be evident, which is a differentiating feature. They are typically highly vascular, meaning they have a rich blood supply, which makes surgical risk higher than for pituitary adenomas.
And something that could be catastrophic if missed. Parasellar aneurysms.
That's right. Aneurysms, abnormal bulges in blood vessel walls in this area, can perfectly mimic pituitary adenomas on imaging and by causing mass effect. Their sudden onset with severe eye pain, intense headaches, and cranial nerve palsies is a major red flag, suggesting possible rupture or thrombosis. Preoperative diagnosis via MRI or MR angiography is absolutely critical to differentiate them from adenomas and prevent a catastrophic rupture during attempted surgery, which would be devastating.
You also mentioned pituitary abscess and sarcoidosis.
A pituitary abscess is, as it sounds, an infection within the pituitary gland itself, or sometimes within a pre-existing adenoma. It can present acutely with AVP deficiency, fever, and severe headache. An MRI typically shows a characteristic ring enhancement around the mass. Requires urgent antibiotics and often drainage. Sarcoidosis, a systemic inflammatory disease, can involve the hypothalamus and pituitary presenting with a thickened stalk on MRI and can cause both anterior pituitary failure and AVP deficiency. It's often treated with glucocorticoids.
Finally, what is hypophysitis?
Hypophysitis refers broadly to inflammation of the pituitary gland, and it has incredibly diverse etiologies. It can be lymphocytic, often autoimmune, especially postpartum, granulomatous, xanthematous, IgG4-related disease, or even induced by immune checkpoint inhibitors, a type of cancer therapy, as well as other autoimmune conditions.
So many causes. How does it present?
It often presents with varying degrees of anterior hypopituitarism, AVP deficiency, diabetes insipidus, hyperprolactinemia due to stalk inflammation, and headaches. Diagnosis is often suggested by MRI, showing an enlarged gland or stalk thickening, sometimes mimicking an adenoma. Elevated prolactin levels and ESR might be supportive. Treatment often involves high-dose glucocorticoids to reduce inflammation, or sometimes surgery is needed for diagnosis or to relieve compression if steroids fail.
This has been an incredible, truly deep journey through the anatomical and clinical complexities of pituitary masses. Now, let's go even deeper into the underlying science and genetics that drive these conditions. How do these tumors actually form at the molecular level?
Fundamentally, pituitary adenomas are of monoclonal origin. This means they arise from a single cell that has undergone an intrinsic somatic genetic alteration, a mutation that happens during a person's lifetime, not inherited. It's not a widespread abnormal growth of many cells, but a single cell's transformation that then clones itself repeatedly.
So a single cell gets a mutation, and it starts to grow. But what's the role of other signals, like those from the hypothalamus or within the pituitary itself? Do they play a part?
While the adenoma's hormone secretion is typically autonomous, meaning it's no longer under normal physiological control by the body hypothalamic hormones, local growth factors within the pituitary, and even sex steroid hormones can create a permissive environment. Think of it as fertile ground that can potentiate that initial single cell's mutation and subsequent monoclonal growth. Even if they aren't the primary cause, they might help it along.
What are some of the key activating mutations or driver mutations that have been identified that kickstart this process?
Two very important ones are GNAS mutations and USP8 gene mutations. GNAS mutations are found in up to 40% of GH-secreting adenomas, those that cause acromegaly. These mutations constitutively activate the GISA protein, which is part of a signaling pathway inside the cell. It's like permanently turning on a switch that leads to increased cyclic AMP-CAMP and sustained GH hypersecretion.
And this affects treatment response.
Yes, these adenomas tend to be smaller and are, interestingly, more responsive to somatostatin receptor ligands. These same mutations are also found in McCune-Albright syndrome, a rare genetic disorder affecting bones, skin, and endocrine glands.
And USP8.
USP8 gene mutations are quite uniquely detected in up to 60% of corticotroph adenomas, those that cause Cushing disease. They are more common in younger women and in microdenomas. These mutations essentially cause an abundance of the epidermal growth factor receptor, or EGFR, on the cell surface, leading to a process called deubiquitination. Simplified, it's like permanently removing a tag that signals proteins for breakdown, allowing a growth-promoting protein to accumulate and drive ACTH production. This helps us understand why these specific adenomas cluster into distinct transcriptomic profiles, which is a refined molecular classification.
Are there other notable mutations or genetic disruptions?
Yes. Others include mutations in USP48, the glucocorticoid receptor NR3C1, which disrupts the body's normal negative feedback on cortisol, the BRAF oncogene, TP53, though rare in benign adenomas, and PIK3CA. These are all active areas of ongoing research, as understanding these drivers is key to developing new targeted therapies.
It sounds like there's a delicate balance of genetic stability at play, and when it breaks down, tumors can form. What about chromosomal instability and senescence in these tumors?
That's a truly fascinating area. Pituitary adenomas exhibit a high degree of aneuploidy, which means they have an abnormal number of chromosomes, either too many or too few. This is more prominent in hormone-secreting types. A protein called PTTG, or pituitary tumor transforming gene, is implicated here. Its abundance is linked to dysregulated chromatid separation during cell division, which directly leads to aneuploidy and, interestingly, seems to trigger a process called cellular senescence.
And what's the significance of senescence in this context? Is it a good or bad thing?
Cellular senescence, a state of irreversible cell cycle arrest where cells stop dividing but remain metabolically active, is actually thought to be protective against malignant transformation. Markers like P21, CYP1, and interleukin-6 are often associated with it. This protective mechanism likely contributes significantly to the invariably benign nature of most pituitary adenomas, essentially acting as a brake that prevents them from becoming cancerous and spreading throughout the body. It's a natural defense mechanism that limits the tumor's aggressive potential, even if it doesn't stop the initial growth.
So, to summarize the pathogenesis of sporadic adenomas, it's a complex mix of disrupted pathways, genetic instability, and a protective mechanism that keeps them benign.
Exactly. The current evidence suggests that sporadic adenoma pathogenesis is largely determined by disrupted somatic signaling pathways, leading to chromosomal instability and that protective cellular senescence, coupled with hormone hypersecretion for functional tumors. While we've identified key drivers like USP8 and GNAS, the exact initiating subcellular events for the majority of sporadic adenomas are still being elucidated. It's a mystery we're still actively unraveling.
That's the sporadic side, where the mutations happen randomly. But are these always random occurrences, or can they run in families? Are there familial syndromes that predispose individuals to pituitary adenomas?
Yes, this is a crucial area. While less than 5% of pituitary adenomas are associated with familial syndromes, they're very important to recognize because they often behave differently. The most prominent are AIP mutations in the aryl hydrocarbon receptor interacting protein gene. These are autosomal dominant germline mutations, meaning they are inherited, that predispose individuals to familial isolated pituitary adenomas or FIPAs.
What kinds of tumors do they cause?
These predominantly lead to GH and PRL secreting types. These tumors are often large, aggressive, and diagnosed at a surprisingly younger age, sometimes before 18 years. However, the disorder exhibits low penetrance, meaning less than 20% of AIP mutation carriers actually develop an adenoma, so it's not a guarantee. Notably, AIP mutation-associated GH-secreting macrodenomas account for a significant portion, about 30%, of pituitary gigantism cases where children grow to extraordinary heights.
Are there other rare but significant familial syndrome?
Yes, there's XLAG syndrome, which stands for X-linked acrogigantism. This is a very rare early childhood onset syndrome caused by X226.3 microduplications, small extra copies of genetic material on the X chromosome. These duplications lead to the overexpression of a gene called GPR101, which constitutively activates GH production, often resulting in extreme height, accounting for some of the tallest reported patients. It's a dramatic example of how a tiny genetic change can have a massive impact on the body.
What about MEN1, multiple endocrine neoplasia type 1? That's a well-known syndrome involving multiple glands.
Absolutely. Up to 50% of individuals affected by MEN1 develop pituitary adenomas, primarily prolactinomas. These are often plurihormonal, meaning they secrete multiple hormones and can be multiple tumors within the pituitary. Screening is crucial in these families. We also briefly acknowledge other associated syndromes such as Carney complex, caused by PRKR1A mutations, often causing GH or PRL secreting adenomas. MEN4 due to CDKN1B mutations, certain SDHX mutations, and NF1 neurofibromatosis type 1. These represent a complex web of genetic predispositions.
This detailed genetic and molecular understanding points powerfully toward the future of medicine. What's the impact of all this on how we'll diagnose and treat these conditions going forward?
This is truly the frontier of molecular classification and precision medicine. We're moving towards pangenomic profiles, looking at the complete set of genes, transcriptome, microRNAs, merinome, DNA methylation patterns, methylome, and chromosomal alterations. These allow for a far more precise molecular classification, distinguishing even those silent subtypes we discussed, and helping us predict tumor aggression with greater accuracy. This detailed understanding paves the way for truly targeted therapies that can be tailored to an individual's specific tumor characteristics rather than a one-size-fits-all approach.
So treatments based on the tumor-specific molecular fingerprint.
Exactly. Imagine a future where we could analyze a tumor's genetic fingerprint and know precisely which drug or even combination of drugs would be most effective, minimizing side effects and maximizing success. We're starting to see this with trials targeting specific mutations like BRAF and craniopharyngiomas, for example. You've truly gone deep today, navigating the complex landscape of pituitary masses. We've explored their anatomical roots, the astonishingly diverse ways they manifest clinically, the intricate genetic drivers that kickstart their formation, and the latest nuanced approaches in diagnosis and personalized management. It's really a field where understanding the what is as critical as grasping the why and the how for patient outcomes.
Exactly. And that's what makes being well-informed so powerful here. Mastering this isn't just about knowing the facts, but understanding the precise dance between these tiny structures, their molecular underpinnings, and the vast, intricate impact they have on our entire body. So what does this deep dive into the molecular why mean for the future?
This raises an important question, doesn't it? As our understanding of these specific molecular pathways and genetic drivers continues to grow, and as technologies like CRISPR gene editing advance, could we one day envision proactive, highly individualized interventions? Interventions that not only treat existing pituitary adenomas, but potentially prevent their formation or aggression before they even become a clinical concern. What new frontiers might open if we could reliably predict which incidentalomas will grow, or perhaps even find ways to induce or manipulate cellular senescence therapeutically to halt tumor growth without invasive procedures?
Using the body's own brakes, essentially.
Potentially. The journey to truly master this information and translate it into revolutionary treatments is far from over, and that's incredibly exciting for the future of medicine in this field.
A truly thought-provoking note to end on, as always. Thank you for joining us on this deep dive. Stay curious, stay informed, and we'll catch you in the next one.